Yes, thank you, Mario. So if you could turn your cameras on, we will be recording this on, Carolyn will be recording this on a phone with our together mode. So I did write in the chat what we're going to be saying. So just say happy retirement, Steve, and thank you for all that you have done for the Implicit Network. So Carolyn, are you ready?
Should we practice that first? That's a sort of a, can we do a practice?
Sure, Mario, we can do a practice.
Only one of us said that they aspired to be an actor or an actress, so I'm not sure we can all get the line right.
All right, so on the count of one, we will say happy retirement. Thank you for all that you have done for the Implicit Network. This will be our practice round, and then we'll record the next one. 3, 2, 1.
Happy
retirement,
Steve.
Thank you for
all
you've done for the Implicit
Network.
Okay, see, maybe we need it. Maybe we could use another practice.
I think it's perfect. It's the beautiful chaos of remote meetings.
All right.
All right, so we're gonna go in 3.
Wait, hold on. Oh, Anna, can we just remind everybody to take their microphones like off mute, because a lot of people are still on mute, so it's not gonna work.
Yes. If you're able to, microphones off mute, cameras on. All right. 3, 2, 1.
Happy retirement. Thank you for all that you've done for the Implicit Network.
Awesome. Thank you very much, everyone. All right. So back to our regularly scheduled programming. We do, in our schedule, we're scheduled to do some updates, but knowing that we are close to our 9:30, which we want to make sure that we give Scott's presentation that time, because we know there's some travel happening. So Scott, I'm going to hand it over to you if that is good, and then please just let Carolyn know when she needs to change the slides. Thank you.
So Anna, my only concern is I'm not sure if Junella and Phyllis are on yet.
Okay, if you want, we can do the updates while we wait.
Yeah, because they were going to log on right at 9:30. And do you want to push back just like 5 or 10 minutes? Is that possible?
That works. So I will then hand it over to Carolyn, and she's going to do a couple updates then.
Good morning, everyone. Sorry about all the jumping around on and off. We're going to start with some network updates and just kind of check in and where we're at with everything. So the big thing is we have a new logo. This is something we worked on. We've been working on it, honestly, for the past 2 years, but we finally got it finalized this past winter. We worked with Passionista, which is a small boutique graphic design company based in North Carolina that Dr. Nargis had worked for before. And so our goal was really just because we felt that our imagery was a little outdated and didn't necessarily represent our patient population or just represent our work. So this is the logo we kind of came up with. It's, you can't tell, it's a mom or birthing person holding a little baby, and then there's the stethoscope kind of wrapping around them, which is kind of resemblance of the network and the provider role. So that's just kind of what it is. We also came up with some new colors, just kind of a fresh update. So we'll be updating kind of all of our material. We've already kind of started that, but you'll see the material being updated as it goes. We have all these files on hand if anyone would like them. They're in Google Drive and we'll share. So, but we're very excited, and we're very pleased with the outcome. So we have some other updates besides the logo. The first being that the implicit toolkit is now live. So this is our updated toolkit. So we spent some time working on this last summer. Stacy kind of led it for us, and the March of Dimes has posted on their website. You can find it at like marchofdimes.org/implicit toolkit, and you can download it. So this is a fresh, it's ICC still, but with just new information, new research, more case studies, and just kind of more background for it. But we were very excited about getting that pushed through. And then we also have a Google Drive. So these slides will be sent out. So everyone will have access to clicking these folders where we hold a lot of our network resources that might be helpful for sites. So this is all kind of reorganized, revamped, so it's more user-friendly. And again, this will be sent out, so everyone will have access to these links and be able to access the network folder, resource folder, and then implementation folder. And if you have any questions about specific material, you can just reach out to Anna or I, and we'll be able to connect you with the right folder where that information is stored. Another one is that our fearless leader, Maha, had her baby back in March. She had her baby boy, and they are very happy. She is still on maternity leave. She'll be returning around June, and we're just very happy for her family and that they're enjoying their time with their new baby. The other update is that I will be transitioning out of the role as Western PA project coordinator at the end of the month. I am moving to Colorado, so I will be transitioning out of this role. We have actually identified a new coordinator and are in the works of getting them started in the middle of May. So there will be a huge gap of not having a Western PA coordinator. We're very excited. Her name is Christy Gross, and she is very smart and talented, and we're excited to see what she brings to the team. I have loved working on this team, and this has been an amazing experience. As you know, I've been here for the past 2 years, and it's been a wonderful working experience. So I appreciate everyone who I've interacted with, and especially my small team with Anna, Maha, Mario, and Stacy. All right. That is all the updates we have. If Scott, you're ready for community resources, we can go into your section.
All right, thank you so much. And well, congrats to Carolyn and best wishes on your next endeavor. We're sad to see you go, but I'm excited for what you're doing next. So I am Scott Hartman again. I use he, him pronouns, and we have this little session on community collaboration right now. And do have some friends, colleagues joining us, and I was just trying to make sure everyone's connecting okay, which is always the challenge. So I'm going to start with a few slides and just framing of what we're talking about, and then want to give a chance at each of our collaborators to talk a little bit about their experiences or their views on collaboration, and then we'll definitely have some time for questions and answers if desired. So Rochester, New York is, I think, one of the 10 poorest cities in the United States. And although we don't have the worst health disparities or inequities, we're certainly up there. You know, as things change in the South, I think the South is probably looking worse than New York. But you know, we still, especially around preterm birth and maternal mortality, we have significant concerns around that. And so I'm presenting some work that's been done here and some views on collaboration to address those inequities. And so first of all, there's this organization called the Healthy Baby Network. And one thing I learned from the Healthy Baby Network and working with them is there's this concept of death by zip code, which is really scary, but you can really look at least in Rochester and the suburbs and neighborhoods, and really see very stark different or distinctive differences in maternal and neonatal morbidity and mortality based just on the zip code of where people live. And I know that's not unique to us, but and I'm not going to present that data right now, but just to frame that. And the Healthy Baby Network is more of a social services network that addresses some of those inequities head on. And there's just a list of all the different things they do there. They collaborate really significantly with family medicine, pediatrics, midwifery, OBGYN. There are a lot of collective programs. Actually, the reason we have centering pregnancy at our residency program is because of a grant through the Healthy Baby Network, a collaborative grant. In more recent years, the Healthy Baby Network has developed this Doulas of Color program that really serves people of color, that has some really exciting outcomes. And so I'm going to talk about a specific project that was a collaboration between Family Med OBGYN and the Healthy Baby Network. And so you can go to the next slide, Carolyn. So we had this PCORI grant that started just pre-pandemic. PCORI is patient-centered outcomes research, I believe. And the PCORI grant is really to focus on like community-based research, and specifically this concept of community-based participatory research, which really engages stakeholders and really uplifts community voices, so that the people that doing the research are not just like PhDs, MDs, DOs. Next slide. And so our specific project was to build this community consortium focused on Black maternal mortality. And then from that to really develop a research agenda and like next steps. So the initial team was a bunch of community leaders and really only 2 clinicians on this team and 1 PhD, so mostly community people, even ministers, doulas, and use this concept of appreciative inquiry to get to know each other essentially. So if you Google appreciative inquiry, there are like whole websites about it, but it's kind of like a qualitative approach to learning about each other and learning about each other's backgrounds, and then studying in a very fluid way the problem that you're addressing. Next slide. And so as we built that team of these sort of leaders or administrators of the project, then we use the qualitative concept of listening sessions, which are also a little bit more fluid than focus groups or interviews. So really, we recruited patients or utilizers of healthcare through primarily the Healthy Baby Network, specifically Black birthing people. And next slide. So I didn't put the questions here, but they were basically questions about your birth experience. And there's certainly a lot of other studies about birth experience, but traditionally hasn't been a lot of focus on qualitative research. And also this team really felt like we needed to address this in the Rochester community as opposed to, a study done somewhere else. So what can we learn about birth experiences in Rochester? And so we did a bunch of listening sessions and then qualitative analysis of the data. Also, the facilitators were people that were some basic research training, but were not like full-blown researchers. Next slide. We can skip that one. And so these are the questions, but basically your experiences in pregnancy and delivery, what interactions went well, what did not go well, what could be done better. Next slide. And so then, as in qualitative coding analysis, we teased out these key themes through the analysis of quotes and things like that from the listening sessions. A lot of the feedback from patients or consumers of healthcare really was about like lack of information and lack of communication. Also address which factors were supportive, like having fathers or support people present, support of specific healthcare professionals. Next slide. And instead of, I'm not going to go through all the negative experiences, but I think if you just glance at these quotes really quickly, it's pretty telling that a lot of this focuses on communication and like lack of expectations not being met. So I was struck by the one who said I wanted a water birth and no one really told me that I couldn't have a water birth at this hospital, despite that they went through all this prenatal care. Another patient that specifically said I didn't want an epidural and felt they were forced into having an epidural. And these are quotes that were pulled out and put into an article, but a lot of these were like recurrent themes. And next slide. And so again, a lot of what people said was, I wasn't told what to expect. I wasn't informed what to expect. I didn't have enough information going into birth. And then there were specific experiences of racism or discrimination against immigration status. Next slide. And we can skip that one. And so what we concluded from the study, this was published. Our next steps are really focused on patient-provider communication as one of the top areas. Of course, dismantling systemic racism is probably should be the biggest goal, but needs to start with engaging stakeholders. And so this group is really focusing on doing more work. And the study that you all know about that we're doing with the IMPLICIT network around qualitative research is moving this into the postpartum period. And so we're using our fourth trimester team or teams in 3 sites in Pennsylvania and New York to do a similar study in the postpartum period. But this consortium I met is really focused on other ways of addressing patient-provider communication. And then last slide. So these are what I would say are some takeaways for all of us. I think you sort of keep hearing me allude to the stakeholders as experts, cultural humility, but also when we think about equity, we think that resources have been taken away from people. And so now we need to put those resources back. And so that's really a redistribution of resources that may be financial, that may be otherwise. I think I will stop there. And so I want to first introduce my colleague, Sherilyn McFadden, and who's just going to talk a little bit about who she is, what she does, and her views on collaboration.
Hello, I am Sherilyn McFadden. Thank you, Scott. I am here in Rochester, New York, and I work with Scott and also Elizabeth with Highland Family Medicine. Some of the things that we do is we connect our patients with community resources. I am a lactation care manager, so we support breastfeeding person's lactation experience. The way that we do that in 4 different steps. We start with the prenatal. That's going to be the 16 to 22 weeks. We start to introduce them to the program. We let them know what they can expect through their pregnancy. We give them support, not only medical. We let them know that there is peer support out there. We will give them the tools for that as well. And then we also let them know if there are family supports. We do tap into that and help them tap into that. Some of our patients, they do come with family members. So we definitely would, sorry about that. If they want their family members involved, maybe it's going to be mom, dad, maybe even father of baby or mom of baby. We definitely want them to know that we always say it takes a village to raise a child. So it does take a village to also help breastfeed, right? So we want to make it as successful as possible in the way that they want. So every breastfeeding experience looks different, and we want to support them in that. The next level is going to be their 28 to 38 week. So what we do in this process, we continue to support them with breastfeeding. We talk about what they can expect in the hospital experience, what's going to take place, maybe, during the birth, the first day, the second day, once they are discharged from the hospital, and what they can expect with breastfeeding experience as well. We do also collaborate with WIC services and let them know that there is WIC out there and that they can sign up for the WIC program if they do qualify. The next step is going to be the first week to the end of the 2nd month. We provide all the lactation support. We do that with not only ourselves, but we collaborate with the doctors that they have as well, and we work together to meet their goals. We support them all the way up until their goals are finished. So some we look at their goals. Maybe their goals are for a year. Maybe their goals are for 6 months. Whatever the breastfeeding person goals are, we're going to support that and meet them where they are. Some of the things that we can do texting. They can text us at any time. We do also in-person visits at home or in our center as well. And then we support them however they see fit. Any questions?
I think we'll also, Sherlyn, we'll leave a little time at the end for questions. So we'll watch the chat for that. But is there anything else you wanted to say about your relationship with the physicians?
So yes, we do have a large relationship with the physicians. We collaborate with the physicians with the different patients. We work together, and the physicians have been a great support with this program as well.
Thank you so much. So I'm going to turn it to Phyllis next.
Unmute myself. Good morning, everyone. My name is Phyllis Sharp. My pronouns are she and her. I am a certified birth and postpartum doula, and also a certified lactation counselor as well too. I have been a doula for about 5 years, and I've always believed in building relationships in my community. So I've collaborated with family medicine team. I've been a part of the centering meetings, as well as discussing like how I can help support patients during pregnancy, labor, birth, and postpartum. I have also partnered with other doctors in hospitals across the city to discuss how we can work together to have healthy moms and babies. As probably hopefully we all know, we are in day 2 of Black Maternal Health Week as well too, and the theme of "It Takes a Village" really rings true. When we say it takes a village, right? So we talk about like collaborating with healthcare teams. I think that's one and the same. So it takes a village to ensure patients and clients have the care that they need. It takes a village to ensure they have safe housing. It takes a village to ensure they have food to eat and transportation. It takes a village to ensure that they have the support that they need. It takes a village to ensure they have health insurance as well too. And it also takes a village for us to be checked on our own racial biases as well too, right? So with this being said, you know, talking about Black Maternal Health Week, we all know the statistics. Black birthing moms are dying 3 times as much as our white counterparts, right? And we're losing babies and we're losing moms. And when we think about collaborating with the healthcare teams, I think about some of the underlying drivers of inequity and eliminating health disparities as well too. So it takes all of us to really work together, understanding one another and our roles as well, to reach the goal of caring for our community and improving poor health and birth outcomes as well too.
Thank you so much. And I'm not sure if Nella was able to join. We're having some connectivity issues. Is she here?
I'm here.
Oh, you are. Sorry, I can't see
Yeah.
everyone on the screen. Thank you. So
Oh,
you're
no,
up.
that's okay. So my name is Nella Goho. I'm a birth doula here in Rochester, New York. I'm also a childbirth educator as well as a lactation counselor. I also have the honor of being the director of education for Dona International. And my pronouns are she, her. My experience as a doula, I have been a doula for 12, going on 13 years in Rochester. And it has been a wonderful experience just to see how the climate of birth has changed. The focus that we've had as a birth community in Rochester has evolved and changed over the years. And just having that spotlight, I'm able to see the growth of so many community programs and the growth of doula grant programs for Black women. So that has been highly encouraging because I remember starting out as a doula, it was a desert. So that has been really great. Um, I enjoy working with family doctors. I find family doctors to be very refreshing. I have always felt like I was a team member with a family doctor, with a family physician. I have always felt included, part of the team. Just seeing the work, that the work and time that they put into their patients. I always encourage my clients, if you're looking for a provider, I always say, there's midwifery and there's family doctors, and I've worked with both and they're amazing. So when I'm thinking about the collaboration that we can have, I think that as we work together, we can tailor health strategies to meet the specific needs of diverse populations, ensuring that everyone has access to the resources and care they need. And this will build trust and strengthen the community's well-being, right? Because that's what we want, is community well-being, and that starts with trust, and trust is heavily lacking, which is why we have the rates that we have and why we have the issues that we have, because we don't have trust in our community, and that stems all the way back to slavery, historically. So who was choosing to buy, telling the master to buy you? It was the doctor. So it's the medical history is already very tension filled. So how can doulas help with this? I feel like doulas can bridge the gap between the healthcare providers and the birthing person. It's like a well-rounded approach where the medical needs are met and the personal needs are met of the patient/client. You're building that trust. The doula helps to build that trust, especially in marginalized communities. And the doula also ensures that their client's voice is being heard, that their cultural, emotional, and physical needs are being met. And so by offering education and continuous support, doulas, we reduce the anxiety, improve birth health outcomes, and enhance the overall maternal health, contributing to a more equitable health system. And we can do that in partnership with family care providers. I'm done.
Thank you so much.
You're welcome.
So I'm just looking in the chat. We do have a little time to take some questions. I don't see any questions yet, so I'm gonna ask one myself. This is for any of the three of you, actually. Nella referred to things getting better or improvement in Rochester, and I'd love to hear any of you elaborate on that.
Well, I'll say something since I brought it up first. When I first became a doula in Rochester, I was the only Black doula, like literally. I had lots of doula peers, lots of people around me that were very supportive and encouraging and mentoring me, but none of them looked like me. And getting clients who were in the Black community was next to impossible, because culturally, why are you inviting a stranger into the room when you can have your mama and your sister and, your family there? And so it was very hard for me to even get Black clients to do births with me. And being the doula mentor at Healthy Baby Network, I've had such an honor of working with a number of Black doulas now. And that always makes me cry, because I just remember looking around. And then when Lakeisha and Phyllis became doulas, like my heart was so happy. And then seeing the grant program come in and having more Black doulas, like, it just blows me away. I went to a training yesterday, and a large table contingent were all Black doulas. And so in that way, that's how I see growth, is in the doula programs that have grown and the collaboration that health systems are now trying to make to combat this maternal morbidity, mortality crisis.
Got it. Yeah, and I'm wondering if Sherlyn or Phyllis, do you have comments on that, on like what's getting better or even what's not?
I definitely, I'm
Go ahead.
sorry. I definitely would like to piggyback off of that. Representation matters. So when you see people that look like you, that is, that can care for you, it matters, and it makes things a little bit better. It makes it feels great. So I think that just like she said, it does make you cry. It makes you feel, that you matter, that, you have somebody here to care for you, that not only you feel that they're looking out for the best of your care, but they do look like you.
And I found even being in the hospital with my Black clients that bridging that gap between the medical team and my client, and some of the things are very cultural. And a lot of times when you go in the birth space, there's not one Black nurse or doctor that's taking care of them, right? And so that brings on anxiety. So we really help to bring down that anxiety as well too. But I feel like the relationship between the patient and the provider is super important. Like Nella was talking about, that trust. And so we help bring that, bridge that gap and bring it together when we're in that birth space with them. So I think that as physicians and providers really begin to see the value of doulas, because some of them still don't see the value of doulas, and how we can really help build that relationship within the hospital, and even before that, and even after that, that we're taking care of these people, that things are getting much better when they have that extra support in the room and someone that knows and can give them education and to help them be able to make sometimes decisions that they need to make. That we don't make decisions for them, but we make sure they have all the information that they need and make sure that they understand what's being said to them so that they can make the best decision for themselves. So we help to empower them to really just be able to have that relationship with the providers that they have in that space, and be able to really have the birth that sometimes that they want, and or be able to make this feel like they're a part of the conversation and that they're helping and making the decisions for themselves. So I feel like that's getting better.
Yeah, thank you. Thank you. I'm not sure if I'm seeing the whole chat. Anna and Caroline, maybe you can help me if there are questions that people have.
Yes, so we have a couple questions. So the first one is, could you give an overview about how funding works for these positions?
Phyllis, do you feel like you can, or Nella, or I can talk a little bit about that too.
Yeah, I think like as far as Healthy Baby Network is concerned, like it's all based on grants. But I worked with Senator Summer Brook to help solidify Medicaid for Medicaid doula services for clients who have Medicaid. So that's now in effect in New York State. So that's part of the funding as well too.
And the work that Charlene is doing is a newer program that is currently grant funded, but our goal is to demonstrate its, breastfeeding and newborn outcomes, lactation and newborn outcomes, that to make it a permanent part, lactation care management be a permanent part of care in primary care offices, and maybe even OBGYN.
Hey, sorry, I'm gonna bust in for a second. That was actually my question. Where did you get the grants from?
Yeah.
Flips,
You know the names? Well, there's Flips grant, which is Finger Lakes IPPS. It stands for something. I think
it's a region.
Perinatal's in there.
Yeah, it's a regional collaborative. Yeah.
Right, and then there's a grant that Healthy Baby Network just got.
Yeah, a year ago. I don't know who it's through. We don't work on that side of the table.
Yeah,
so
we don't know that side. We just know that there's money and that it runs out. And so you have a program, and then sometimes the money runs out and the program goes womp womp. So that's the only annoying part about grants.
So there's a program called ASTHO, ASTHO, and I can't remember what it stands for, but it's under the CDC, and they fund a lot of perinatal projects. And that's where our lactation started. And then it's actually like the Accountable Care Organization has an equity section that picked up and is further funding the lactation program.
Right.
So, but I think that ASTHO is something to Google and look for their money, because they're in a lot of states, and they'll fund things that are pilots, but they can be like a couple year long pilots.
One of the grants we got was through Kellogg's. I think Twyla Dillon, she wrote a grant for Healthy Baby Network from Kellogg, and they gave us a couple, like 2 million or something. I believe that's what helped to cover some of the doula costs. So, yeah. I wish I knew the names of them though. I can probably get the information and shoot it over to Scott. And he can shoot it over to you.
Thank you. Anna, were there other questions that we didn't touch on?
Yes. So do the doulas work for the hospital health system in the Rochester area?
No,
No.
we're all independent of the hospital system. The hospitals are starting to seek doulas, private doulas, when they have clients that they think need a doula. There is like a resource list of people they can contact, but none of them are employed to the system. They're all independent.
So the next question is kind of similar to that. So are doulas independent or employed by a group, which I think you answered, but I would love to have a doula involvement with our births, but don't know how to make this happen. And this is coming from Dr. Seams, who's a provider in Altoona, PA.
I'm not quite sure where Altoona is, exactly. But they do
It's in
have
the middle
doula
of the state,
programs
in the
there?
middle of nowhere.
In the middle of nowhere, okay.
Yep.
I think, I'm quite sure there's probably doulas in your area or close to it. If you would, you can go on the DONA website and see if there's any certified doulas like near you, because they have us all listed on the website, and it tells you where they live. So you can like put in your zip code and then be able to like connect with a doula there, and start a relationship.
The way we did it here in Rochester, it was actually streamlined through we have a couple doula agencies here in Rochester, and they're really just a group of doulas getting together. We're all basically still independent, but we're under one name. And we found out that they were interested in a need, and so the owner of BBC basically put out a call to the doula community and said, is there anyone willing to be on this list for a call if a midwife or a doctor or a nurse feels like this patient needs a doula? And a number of doulas were willing to do it. And it would be for free. So, because the hospital wasn't paying. So it would have to be like a doula coming in to do, a service.
Yeah. And that's, we do it mostly if someone's birthing alone, or if there's a loss sometimes and they still have to labor. So those are like opportunities for us to come in and to help support as well too.
Right.
Thank you.
Right. Go ahead, Scott.
No, I just want to, were there more questions? Sorry, I can't see the chat.
No problem. There's another one. So this is from Dr. DeMarco. I think this is fascinating. One struggle I have is that as obstetrical hospital providers, we train to work together as teams. When a doula comes in, it's like having a new team member that we are not used to working with. Can be very challenging if the health system hospitals are not supporting this line of service staff.
Yeah.
That's a really good point. It's so funny that you brought that up because Jenny Joseph from Orlando, she has the JJ Way. She was here just yesterday doing grand rounds, and I got to hear her speak, and she spoke on that very thing. I don't, Phyllis, you can add to this, but I think when you're thinking about like a team working together, you have to be mindful and intentional. It's not this I think Rochester is a very unique area because we have so many doulas. We have a lot of doulas because one of the first members of DONA lives here in Rochester. And so she's a DONA doula trainer. And so she trained a lot of doulas in this area. And so it's not the norm here. So I mean, it's not the norm everywhere. So what I'm about to say, if it doesn't apply to your area, I apologize. But we're our providers will go out of their way to do mixers with doulas. Doulas are invited into the hospital. They do tours with the doulas. This is what this is how the floor works. And this is where the nurse goes when they do this. And this is what the OR is. And they do that and they do mixers. And the midwifery group has like a once a month, they have an open house that you can come. And so we have actually been able to build relationships with providers here in Rochester because of that openness and that intentional, we need to get to know you because you're going to be working with us. I'm not sure how that works in other areas, if providers would even be open to that, depending on the doula life out there.
Yeah, and I'm going to really, like, all doulas are not the same either as well too. So I had the opportunity of spending time with U of R OB residents last October, and just talk with them about, like, so what do the attendings tell you about doulas? And they said, oh yeah, they tell us that they have a doula, they're gonna have an outrageous birth plan, and all of these things. So there's biases about what doulas do, right? And that our clients are going to be asking, our patients are going to be asking for crazy stuff and da 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 da. So all doulas are not the same, right? We are not supposed to be telling our clients what to do. We're just supposed to be educating them, right? So that they can make their own. We're empowering them to make their own decisions, right? If a client asks me, Phyllis, what would you do? I'm like, it's not my birth, it's not my body. I'm just going to give you the information, and then you need to make your decision on what you want to do, right? So, so in saying that, all doulas are not the same. So I want to make that very, very clear. So that can be hindering, like, the relationship, in your hospital when they look at doulas. We've had experiences with doulas, and so they think all doulas are the same, right? And so, but we're not all the same. So I think,
just like doctors aren't all the same. You got one doctor who might be like, blah, and then everyone's like, oh, all the doctors in that practice are that way, but that's not true.
And just getting to know them and making them feel a part of the team. Like Nella said, we feel very much a part of the team. I do in all 4 hospitals that I go into. When I walk into a hospital, they know me by name, almost everyone on the floor. And so that's the relationship that I have built with the hospitals that I deal with. So I think that a lot of times as a Black doula, with all the health disparities, right? We're thinking about that, and we're thinking about some people come in. I had 5 wonderful births at Highland Hospital. My doctor was Black, Dr. Shabangu, and I had wonderful births. I became a doula because I wanted everyone to have a wonderful birth like me. I didn't become a doula because I had this horrible birth trauma, and now I'm walking in the door thinking I'm supposed to save everyone. you know what I mean? And so the mindset of the doula is very important as well too. I don't come in ready to fight, but I know doulas that are coming in like ready to fight. That's not how we should be coming in. We should be coming in expecting the best outcome for our client, and we should come in expecting that the providers all want the same thing. We all want the best for our patient client. And I think sometimes because of all the things that are going on, that sometimes doulas don't have that mindset when they walk into the door, right? And so we have to think about, like, all of these things, the anxieties of our patients and clients when they're coming in. They're scared. I mean, my clients are every nationality, and they will call me, and I have a white woman will call me and tell me she's scared to have her baby in a hospital because of the disparities, right? So when we think about that, we're supposed to be bringing that anxiety down as doulas, right? And making sure that we're all working together to make sure we have the best outcome possible. And so we have to think about, like, the mindset of the doulas, and when we bring them in to talk with them and chat with them, and even if you bring them into your office, just your office alone, to meet your staff and say, we're having this doula day, we want you guys to come in and meet our staff, and we want to be able to kind of work with you take a look at that. And those are things that we can do to help build the community as well and work together. Like I said, you know, it takes a village, and it takes all of us really working together to be able to make this thing work for all of our patients and our clients, to make sure we have the best outcomes possible.
And I just want to add that I think it's possible, Dr. DeMarco. I think it's very possible. It's just being intentional. We have a hospital system here that historically doulas have felt were not doula friendly. And they have done a complete 180. In fact, they invited all of the Black doulas I mentor in to the obstetrics department, and they had the head doctor for OBGYN meet with us. She basically told us she was so glad that we were there and that they were going to partner with us to bring out better outcomes. And so they talked with us, they asked us questions. What are things that you find in the room? What are suggestions that you have for us as providers? Like, it was heartfelt, and I feel like that those are the ways that you kind of open that door with doulas.
Yeah. When you have a place that you go into, you don't feel welcome. And it was very true in one of the hospitals here, where it was a point where doulas wouldn't even take clients that went to that were birthing at the hospital. That's how bad it was. And they have done a complete 180, and we feel more welcome there now.
Yeah.
Thank you so much. I really appreciate Sherlyn, Phyllis, Nella for joining us today, and the tremendous work that all of you do. And I'm glad that your co-conspirators with us in advancing equity. I think I need to turn it back over to Anna to keep us on time.
So we do have one last question that I think we can have time to answer. And then I did want to just let everyone know, again, the slides will be available after, and any additional information we're collecting, we will make sure that we disseminate it to you all. So Dr. Seams asked, are the doulas involved in prenatal care in Rochester, or are they mostly involved in the birth and after?
So that really depends on when we're connected with them. You know, I've had a client hire me when they were in the hospital for an induction, and I've had someone hire me before they even got pregnant. So, so it varies when you start your relationship with them. But we're involved with them during prenatal care. We really like that. We get to know them, get to know their family, get to know what their needs are, really be able to talk to them and really get to know them. So that we're ready, you know, when they do go into labor. And so we're there for the birth. We're there after. All doulas are different when it comes to postpartum care. I normally take care of my clients for at least 4 to 6 weeks after they deliver their baby. I will see them and speak with them and make sure they're doing okay mentally, physically. I've had to even like send clients back to the hospital because they were showing signs of preeclampsia after they had the baby. So, you know, we really watch out for those signs for our clients, even before and after. We have them count the kicks. We have them make sure they have a blood pressure cuff at home. So all of these things we're doing prenatally to make sure they're doing okay.
I would add to that, that, like Phyllis said, some doulas are different. If you're dealing with an agency, the agency normally has a standard of care that they provide. So all the doulas, you know, take clients up to a certain point, and all the doulas meet with clients afterwards up to a certain point, you know, whatever that agency's preference is. With independent doulas, it's up to them. And so when clients interview with them, they'll say, like, you know, I don't become involved until 30 weeks, or they'll say, oh, you can hire me now, and I will help you with any of your visits you have, if you have any questions on that, or I'm available to you throughout your whole pregnancy. It's just unique to that doula, and then the clients decide if that's the type of doula they want or not.
Thank you very much. And thank you for the wonderful presentation. I think there's a lot of great information that you provided with us. If you are willing, I would love if you could share some contact information in the chat if people have additional questions. If not, we can also go through Scott, and then I will have us go into our next section, which will be grant updates, which will be timely since most of our, thank you very much for attending. Since we heard a lot that grant funding was supporting a lot of these community programs. Mario?
Hello and happy mid-morning. I feel like we need a sort of 7th inning stretch break so far, but I know we have a long way to go. I did want to provide some updates on where we are with grant funding, and I know this is not news to anybody that's been part of the Implicit network for a long time, but just to really elevate sort of the role of funding that is required for our network. This is not a the implicit work that we do is not a reimbursable medical service. It's really not a line of service that's supported by health systems or practices. And so this is a, sort of a collaborative network, an innovation network, implementation, some research, education. It does take money to sort of have a network to bring people together, to grow that and provide peer support, implementation support, EHR support, advocacy resources, education, workshops, webinars, to pay our staff and those types of things. And so I think we've been running the network for as few dollars as possible over the last 5 to 7 years with funding from the Department of Health in Pennsylvania. Although our network does have significant reach outside of Pennsylvania and really is sort of poised, I think, to have a national reach. And so I want to talk about a couple of things that are happening. Hopefully these spur some ideas. The point that Anna just made about the grant funding that's gone on, the doula support, which, as you heard and as you can see, doula support can help mitigate against health inequities. It could help integrate services in the postpartum period. It can improve maternal health and infant health outcomes. It's all the things that we hope and dream from the work that we're trying to do. It is not directly our model of care, but it's sort of related. And so, if we can figure out how to get 4th trimester work to integrate, doulas into labor and delivery and that sort of stuff, there are ways that this overlaps. And we want to continue to think about projects, grants, and opportunities that are happening in your states and your institutions, in which we can build connections to the work that we're doing with Implicit. So there's not a lot of slides. I think it's just this one. I want to provide an update that we are coming up to the end of year 4 of a 5-year supported grant from the Bureau of Family Health through the Pennsylvania Department of Health. And this has been, the major source of support for our network, and really, has been a tremendously successful for our Pennsylvania network. So when this particular grant funding started 4 years ago, we had grown from 5 to 12 sites in Pennsylvania. We've continued to add sites, in Pennsylvania to create a network. We now have 15 or 16 sites. All of them are sharing data with the Implicit network, and which is not true of all sites across Implicit. And so it really, there's a value of having staff that are working in the state, that know the sites and know the site champions and have regular meetings and all that stuff. It does work, but it costs funds. And so, that has been tremendous, and it has opened up the door for us. This is the second time that Pennsylvania has funded interconception care through a non-solicitation award, meaning that we were the only people doing it. We wrote a grant and it was not competitive. So we didn't have to compete with other people. They will move on from funding interconception care at well child visits after the cycle is up in June. It is the first time that Pennsylvania Department of Health has funded the 4th trimester work. So there is a possibility that the work can be extended in another cycle, although we're told that would be a competitive grant cycle. And so, we'll wait for some additional information. As I said, we have another year, but we do have to come up with a plan, because you can't keep staff not knowing if the work is going to continue after the next month. And so we need to hire and retain and keep staff and know what our future plan is. So we will continue to work with our partners at the Pennsylvania Department of Health to try to figure out that funding, and also hoping that other states are submitting and providing funding so that we can have a network staff that isn't reliant just on the Pennsylvania Department of Health. More recently, Pennsylvania has applied for the HRSA State Maternal Health Innovation Grant. So far in the United States, 35 states have gotten this type of award through HRSA. Pennsylvania is one of the few that has not until now. We've recently applied with our, again, supporters and friends at the Pennsylvania Department of Health and in collaboration with the Jewish Healthcare Foundation. This grant would bring $1.5 million for 5 years, a year for 5 years into Pennsylvania. And we did propose that the IMPLICIT network would be part of the implementation team, a significant piece of the implementation team that would fund the work that we're doing to support counties in Pennsylvania that have the highest rates of maternal morbidity and mortality or the highest health disparities. And those would be determined by the Maternal Health Task Force as part of that grant. So this would change the work of IMPLICIT from being a family medicine residency type of support network to really a practice health system implementer, partner, collaborator, but that's where the funding is, and we're going to continue to try to expand that work and try to do that in the areas of highest need. So that grant was submitted this month. It's supposed to start at the end of September. I think we have a high likelihood of getting it, and we'll find out this fall if that's the case. There is an opportunity for a PCORI grant that would directly look at and potentially fund evaluation of the IMPLICIT network. Again, PCORI is Patient-Centered Outcomes Research Institute. These are typically big awards, but require a lot of science. This is a methodologic type of work. We did submit a letter of intent in February that was accepted. And so we got an invitation to apply for the full grant. And so they can either like your idea or not like your idea. They liked your idea and we got an invitation to apply. That would potentially be due in early May. It's possible that we could defer it into the fall. Depending on the resources and whether or not we're prepared to do that. We are proposing looking at a fourth trimester evaluation that would look at sites in the IMPLICIT network that are implementing or not implementing fourth trimester and look at maternal health outcomes, and also sites that are not part of the IMPLICIT network that are either invited to implement fourth trimester or not, which is the current standard. A non-IMPLICIT site that's not doing fourth trimester care is just sort of the status quo. But that's, a lot of evaluation and looking at outcomes, and it's very methodological, and you have to have good comparison groups. And we are partnering with some researchers at Penn and CHOP and with Sarah Verbeest in North Carolina, who has experience with this type of grant, has worked with Nargis for at UNC as well on different patient-centered outcomes research projects. And so that is in the works. A partner of ours and a supporter of IMPLICIT, Emily Gregory, who's a researcher and a pediatrician at CHOP, has submitted an award for an R01 grant. I think that this, sometimes these are funded right off the bat, but oftentimes they're you get to revise and resubmit those. But this would really look at whether or not the IMPLICIT ICC model improves birth outcomes in subsequent pregnancies, which is really the thing that we expect to be the case, but we've never been able to test it because it requires approximately $499,000 a year for multiple years to basically do that type of evaluation. And so more than we can afford, but we're looking for funding to look at that. That would mostly be looking at Pennsylvania sites in the UPMC, Lancaster, and Philadelphia areas to see if these practices compared with non-ICC practices change birth outcomes for those birth parents. And then finally, there's a couple of opportunities to do the work that we're really, really good at, which is forming collaboratives and learning collaboratives. The American Board of Family Medicine Foundation has made a couple $1 million available to try to expand work around learning collaboratives as part of GME funding. And so we thought we would apply for this. FMEC would apply for this for Implicit. FMEC actually was invited to submit their own application, which I have confidence would be funded because they're already an incubator and a collaborator and a bringing people together type of organization that forms learning networks. And they're doing this with Implicit and ovarian cancer and some other things. And then we submitted one just for the Implicit network to expand and bring on new sites that are outside of our typical Implicit geographic domain. We did receive confirmation that we received that award, but we have not received the check for that award yet. So that's something I think that we can anticipate having in our coffers to fund additional staff and to bring on an additional sites in a region, like maybe Colorado, for instance. So we'll stay tuned about what we can do with that funding award, but that will help support the Implicit network over the next 18 months. And so those are some active things. I do, there are a lot of people that are part of the Implicit network that have some grant writing experience and have been through this process in their sites and states with various degrees of success. But just like quitting smoking, the more times that you fail, the closer you are to success. But we really do. We have a lot of data. We have a lot of resources. We've failed many times to get grants, and so we've learned from those experiences. If you think that you have an opportunity for a foundation grant or a regional grant or an institutional grant or anything that comes across your desk, and you would like to sort of know if this fits for something that the Implicit network could apply for, please reach out to our team. They can connect with me or Amy or Scott or Nargis, lots of people that might have some ideas about this, and to frame this in a way that could be very positive. I think Implicit is a very strong grantee. We're a strong network. For 20 years, we've been having spring and fall meetings. We have infrastructure, we have team, we have data, we have EHR capabilities. This is not the norm for practice-based networks. And so just want to share that I think that we get a lot of attention, and we're pretty close to getting some big federal awards for the type of work that we're doing. And that's sort of just an evolution of where we are. But it does take a lot of tries to get those things, but I think we're getting really close. And there's a lot of great ideas that we can do to make progress on sort of our main projects as well as our health equity focus.
Thank you very much, Mario. I would invite anyone, if they have any questions or any information about potential funding, please put it in the chat and we can continue that conversation. Carolyn, if you would like to go to the next slide. So now we're going to have a section on ICC. So first we'll have Brianna Moyer do a presentation, and then Mike will present some behavior change data. So, next slide.
All right, thank you, Anna. So I'm going to talk a little bit about ICC, specifically about interventions when positive risks are identified. And so what we're hoping to do is kind of cover the range of interventions, and then talk about some strategies of how to integrate them kind of in an efficient way and an effective way within the context of a well child visit, because I know that can always be a challenge trying to figure out how to fit that into what's already happening within the well child visit. So just to review, with ICC, as we all know, we are screening for risk factors specifically for smoking, depression, family planning, and multivitamin use. And what counts as a positive risk is very specific for each of these risk factors. So for smoking, a positive risk in terms of the data is when the patient identifies, or the mother or birthing person identifies that they are a current smoker. For depression, what counts as a positive risk is a positive PHQ-9, and we're using that as a score greater than 10, or if you're using the EPDS, a positive EPDS. For family planning, what counts as a risk is if the patient or the mother or birthing person identifies that they are using no method. And then for multivitamin use, what counts as a positive risk is if they're not currently taking a vitamin. And so from a data perspective, it's important to recognize that these are the specific things that count or qualify as a positive risk factor, but that we may still be doing interventions or talking about the intervention options for other reasons. So for example, with family planning, you will find that even if the patient is using a form of family planning, such as condoms, a barrier protection, natural family planning, you will likely still get a prompt if you're using the EHR build of ICC to click an intervention. And that is not because we are saying that this patient has necessarily a positive risk, but that we are encouraging confirmation that they're satisfied with their current method of contraception. So as we go through each of these, we'll kind of talk about that, as there may be times where you're still being asked to document an intervention, even if it isn't necessarily a positive risk factor. And that is just to confirm that the patient has the resources that they need and that they're satisfied with the current plan of care. So we can go ahead to the next slide, please. So this is a really nice graphic that just goes through all of the ranges of interventions that can be offered for positive risks with ICC screening. And you can see they range from least intensive to most intensive, involving things such as just having a conversation, providing education material, and then as intensive as actually providing prescriptions or a separate visit for the mother or birthing person during the time of the well-child visit. And so we're going to go through each of these risks in detail and kind of some strategies for how to employ these interventions. So next slide, please. So I have just like a short case for each of the risk factors here. So specifically for smoking, the case here is a mother birthing person coming in with an 8-month-old baby and fills out the ICC form during the visit and checks that she is currently smoking. You ask her if she's interested in quitting, and she says no, she's not. You tell her that she can come back to you if she changes her mind, because there are many benefits to quitting for both her and her baby. So does this count as an intervention? And the answer is yes, it does. And you can see how this is a very kind of quick conversation that can happen in the midst of your well-child visit that can be an intervention. So next slide, please. So this goes through the range of interventions for smoking in particular, and you can see that kind of the least intensive version is just talking about quitting or reinforcing cessation if this is a former smoker who has already quit. And so some thoughts, recommendations for this is thinking about having a script, especially for resident learners, sometimes giving them some scripting or some tools that they can use during the well-child visits can help increase efficiency. So for example, giving them a script such as, there are many benefits to quitting smoking for you and your baby. Is this something you're interested in discussing today? And if the patient or the mother birthing person is interested in discussing it at that time, certainly having a further conversation. If they're not, that still counts as an intervention because you acknowledge the risk and you brought to the forefront the fact that there would be benefits to quitting. Patient education materials is another great way to incorporate interventions that's pretty low time intensity. Our recommendation would be to have these accessible. And so I think there's lots of ways to do that, whether they're in the room, you have a resource like within your clinic somewhere where you have all of the education materials, or integrating them into the electronic medical record so that they can be added automatically to like after visit summaries or other things that the patient will be receiving after their visit. Certainly referring to a quit line or a community resource or scheduling a follow-up is kind of the next level of intervention. And a great idea here is to have like a pocket card or a wallet-sized card that has helpful phone numbers. So I know this is something we have in our clinic where it's just a wallet-sized card that has like the crisis intervention phone number. It has smoking cessation hotlines. It has a lot of resources even for like food banks and housing resources in the community, and all of those numbers are on one small card that can easily fit in someone's wallet. So an easy thing to be able to give, doesn't take a lot of time to do that during the visit. Next level intervention would be thinking about actually prescriptions, whether that's nicotine replacement or another prescription to aid in smoking cessation. And I think the way to kind of maximize time efficiency here is having a workflow for your clinic of what that would look like to do that during a well child visit. So certainly that could be just going into the mother or birthing person's chart. I know in our clinic we use like a telephone encounter within the chart, and we send the prescription that way. Or if you have the ability to do same day appointments or add-on appointments, if a mother or birthing person is a patient in the clinic, that can also be a really great way to have the time and the space to address this and write the prescription. And certainly then there would be the reimbursement associated with the visit as well. And then the 5 A's is a great framework if you have the time that day to do a kind of more intensive intervention. And when we're doing these types of interventions, this is something doing some role plays, especially with resident learners, can be really helpful. We do that as part of our ICC training. We do some role play events where we have residents practice with each other doing the 5 A's. We do it for family planning interventions as well, just so they can work with this framework before doing it in front of a patient. And that helps with their confidence as well as helps certainly with efficiency. So we'll go to the next slide, please. So now we'll switch over to depression. So our scenario here is that at a baby's 1-month well child visit, the mother birthing person scores over 10 on the PHQ-9. Unfortunately, she says she doesn't really have time to talk about her mental health because she's running late for work. You confirm that she's not having any thoughts of harming herself or anyone else, and you give her the purple crisis intervention card and explain how to reach out by calling the numbers on the card. So does this count as an intervention? And the answer is yes, it does. Certainly, there's a lot more intense interventions that could happen or that maybe we hope would happen in that visit. But, if you're strapped for time or the mother birthing person is not able to take the time at that moment, giving the correct resources or working to schedule a follow-up would count as an intervention for that positive risk. Next slide, please. So if we go through the interventions here for depression, kind of from least intensive to most intensive, again, having those patient education materials in the room, thinking about having that pocket card or wallet card available with phone numbers on them. And then also talking with them about if they're in any type of treatment, currently taking any medications, checking in about the current plan. And that's something we talked about too, like even if the patient does not screen positive as a true positive risk, meaning their PHQ-9 is not greater than 10 in that moment, but they have a history of depression, this is where checking in with them and just saying, how are things going? Are you connected with somebody? Are you seeing a counselor? Are you on meds? Are they working? That can be a really quick kind of check-in intervention that can happen during that well child visit as well. In terms of scheduling follow-up visits, again, having that workflow set ahead of time can be really helpful, whether this mother birthing person is a patient at your office and you have the ability to schedule like a short interval follow-up, either same day or later that week, or if they are not a patient at your office, having the ability to reach out to the PCP and connect them with services fairly quickly. In-visit counseling with the provider certainly is a great skill, something that is going to take a little bit more time. And so again, having those role play scenarios, especially with resident learners, can be really helpful to just have the skills and the confidence to do that in a time efficient manner. And then certainly most intensive would be an actual warm handoff to a behavioral health provider. And I know not all clinics have integrated counselors or behavioral health providers, but certainly if that's a resource that it's available, or if you have social work team embedded in your clinic or other integrated sources, having a workflow for how they can be notified maybe even that same day to reach out to the patient or even see them before they leave the office to connect them to resources moving forward. Next slide, please. So looking at family planning, our scenario here is a 12-month well child visit where you ask the mother birthing person about family planning. She says that she's not currently trying to get pregnant, but she would be happy if she did get pregnant. She's not doing anything specific for family planning, and she specifically is not interested in hormonal methods of family planning. You discuss with her the recommendations and benefits of birth spacing and explain that there are non-hormonal options for family planning if she would like to discuss that further, and she tells you she's not interested in talking about it anymore today. Does this count as an intervention? And again, here the answer is yes, it does. And so I think, again, just emphasizing that having that conversation, providing, just a small amount of information about birth spacing and recommendations is sufficient to count as an intervention for these positive risks. So next slide, please. So this slide goes through, again, from least intensive to most intensive, what options there are for interventions for family planning. The one that I really emphasize with our residents is just talking with patients about the recommended interpregnancy interval and the benefits of waiting, and also exploring, the patient's reproductive goals is very important. And again, this is an opportunity to have a script where you're talking about, what are the benefits, excuse me, of birth spacing, and just talking with them about that recommendation. I find when I incorporate this, a lot of times mothers or birthing people haven't necessarily heard that recommendation before, or don't understand that there may be benefits to having a particular amount of spacing between pregnancies. So providing that information can be really helpful. I think especially with family planning, having a good resource for education materials, and certainly IMPLICIT has lots of resources that we can give, and there's lots of good resources online for this, but having a handout that kind of goes through all of the different methods and the pros and cons can be a really great way to provide information if you don't have the time during that well child visit to go through everything in detail. And then this is where we talked about reviewing current method satisfaction. We really recommend doing this for everybody. So even if the mother birthing person identifies that they are using contraception or family planning and they're not technically don't have a positive risk because they are using something, it is really helpful to just confirm with them that they're satisfied with their current method. And so I think that can be as simple as a conversation like, I saw that you checked that you're using Depo. How's Depo working for you? Are you happy with that? Or do you want to talk about other options? And often that may be, they may just respond with saying, yep, I'm doing great, no concerns, and then you're done. Or if they say, I am interested in switching, or I have concerns about the bleeding, that can then lead to either a further conversation or the opportunity to provide education materials or set up a follow-up visit. In terms of kind of next level intervention, certainly setting up an appointment for the mother or birthing person to discuss or to receive family planning methods is a great opportunity if you identify that they're interested in that. One thing that I often advise when I'm talking with residents about this is offering a prescription for emergency contraception. That's something that could be done at the time of the well child visit pretty easily. So that way, if they're not going to be able to get scheduled for a week or two to get whatever method they desire, just giving them a prescription in the meantime, if that would be helpful for them. And then in terms of the actual discussion, we do have some great education resources about the PATH framework and how to use that as a conversation starter. And this is a great opportunity for role playing as well. And then, of course, the most intensive intervention would be actually providing birth control during the visit. And again, having an established workflow for how to do that ahead of time can be really helpful in terms of efficiency. So next slide, please. So I'm not going to go into a ton of detail about the PATH questions because I know that we've done that at other IMPLICIT meetings, but just a reminder that the IMPLICIT network does have a really great kind of training PowerPoint with education materials about how to introduce the PATH method to providers. So if that's something that would be relevant to your practice or to your program, definitely reach out to the coordinators about that. But the PATH framework is just a framework to have conversations about family planning, focusing on kind of three main questions. So the PA standing for parenting and pregnancy attitudes, asking about if the mother or birthing person thinks that they want to have children or have more children at some point, asking about the timing when they think that might be, and then how important it is for them to prevent pregnancy until that time. And that really helps to frame the conversation so the focus can be on family planning methods that fit within the kind of the goals and wishes of the birthing person. The next slide, please. And then finally, we'll talk about multivitamins. So our scenario here is a mother birthing person at her baby's 18-month well child visit. And on the ICC form, she marks that she's not taking a multivitamin. When you ask her why she stopped taking it, she says she's no longer breastfeeding, she has an IUD, and she's not planning a future pregnancy in the next year. So you discuss with her the recommendation to start a prenatal vitamin or a multivitamin with folic acid 1 to 3 months prior to conceiving if she decides to become pregnant in the future. So does this count as an intervention? And again, the answer is yes, it does. You're talking with the patient, providing information about why a multivitamin would be recommended, and discussing when an appropriate time would be to start one based on the reproductive goals of the mother or birthing person. And I think this is a question that I get asked a lot when I'm kind of doing training with the residents, is like, if the patient has an IUD, they have an Explanon, they're not planning on becoming pregnant, do I really have to talk to them about a multivitamin? Is there really an indication for it? And so I think certainly there is the recommendation that all women of childbearing age can benefit from a multivitamin with folic acid, but certainly sometimes patients don't want to take it because it's causing constipation or it's one more thing to remember. And so I really emphasize in those scenarios talking about the focus of starting it 1 to 3 months prior to conceiving, and making sure that the mother birthing person is aware of that recommendation, that they know they can always reach out if they're planning a pregnancy, so that we can get them connected with a vitamin while they're trying to get pregnant. So next slide, please. So again, going from kind of least intensive to most intensive options for interventions for multivitamin use, like we just talked about, just talking about the recommendations for when we should be starting multivitamins in the setting of trying to conceive, providing patient education materials, providing a prescription, coupon, or voucher for a multivitamin. And if you have a hospital pharmacy or a pharmacy within your clinic or health center, or a local pharmacy that many patients use, sometimes coordinating with that pharmacy to have for them to accept coupons or vouchers can be a really helpful way to do this. And then certainly the most intensive version would just be actually handing the mother or birthing person a bottle of multivitamins with folic acid in the clinic. And this is something that I know a lot of sites have done based on applying for, like, having grant funding that they're able to have multivitamins in their clinic, and then also coordinating with other community organizations, just like we heard about earlier. But I think in our health system, we have Healthy Beginnings, which is a nurse and social work program that's able to connect with pregnant patients who have Medicaid, and they often have funding to provide things like multivitamins, blood pressure cuffs, etc. to patients. So connecting with those organizations or looking for funding to have multivitamins available in your clinic can be a great way to do this intervention pretty quickly. Next slide, please. So now that we kind of talked about the range of interventions and how to incorporate them, I think a few strategies or thoughts about how to do this in a time-effective manner, because I know that's always the biggest challenge, is recognizing that, this is the well child visit. There are already lots of things that need to happen within that well child visit for the child. And we also want to spend time addressing the concerns of the mother, the birthing person, but making sure that we're doing that in a time-effective manner. So I think, as we already mentioned, having patient education materials available in a very accessible way is a great opportunity to be able to do an intervention pretty quickly. One thing that we've trialed at our clinic is what we call our ICC binder, and it's exactly like what it sounds like. It's a big 3-ring binder. It's got plastic sleeves in it for each of the risk factors, and so we just have a bunch of pamphlets about smoking cessation, multivitamin use, family planning, etc., all in this binder. And then the idea is that the binder comes into the room every time there's a well child visit that ICC is being done. Certainly it doesn't happen every time, but that's the ideal, is that as the clinical staff is rooming the patient and having the birthing person or mother fill out the ICC form, they put the binder in the room so that when the provider goes in to review the form, if they identify a positive risk, they can just open the binder, grab the information, and give it to the patient in that moment. I think incorporating the patient education into the EMR is also really helpful, and I know a lot of sites have done this. We at our site have dot phrases in Epic that we can just type into the after visit summary. We have one for each of the 4 risk factors. So that's something that, you know, if there's a positive risk, you can just quickly go into the after visit summary, type those in, and the information's already there. I think developing a workflow for multivitamins in the office can be also a really effective way to intervene for the multivitamin risk factor. We have tried a couple different things in our clinic. Our main residency clinic is connected to the hospital, and so we've done a voucher system with the hospital pharmacy where patients receive a voucher from our clinic, they go down to the pharmacy, hand in the voucher, and then get a free bottle of vitamins. We also most recently had some funding to be able to get vitamins directly in our clinic, and that way we can just hand them out and the patients don't even have to walk to the pharmacy. And then I think, like we also discussed before, creating a scheduling workflow for how to do those short interval follow-up visits, so that if it's identified that a mother birthing person needs a visit, there's already a system of kind of how to get them scheduled. So I think things we have tried is if the if the provider has time, actually adding the mother birthing person as an add-on visit that day, certainly needing to check with the mother birthing person about that, because that knowing that may lead to copays, etc. But that's one option. Or we sometimes also have availability with our APPs in the office. So even if the provider seeing the child for the well child visit can't do an extra visit, there may be an opening in the APP slot. And if the mother birthing person is able to stay, you know, a few minutes longer, they can be seen that same day. If that doesn't work, having a plan for how to get them in a short interval. And then if you're seeing a lot of children, but not having, like the mother birthing person is not a patient, having a good workflow of how to communicate with the PCP to be able to get the patient seen pretty quickly. Next slide, please. And then finally, just some thoughts about how to improve intervention rates for ICC. So I think one of the basic things, but really important things, is just regular education of providers and clinical staff. And this is something that we've seen in our own clinic, just with a lot of staff turnover, knowing that we have new residents every year, just having like a set schedule of how we educate. So we've been trying to incorporate this into our like resident kind of block conference or didactic conferences on a scheduled basis every year, so that they are seeing this over and over. We've been doing updates at our clinical huddles in our clinic, so that clinical staff are on board. And we've been trying to kind of integrate and empower clinical staff to get involved. So if they're recognizing that as the patient is filling, or as the mother birthing person is filling out the form, that there are positive risk factors, empowering them to actually get the handouts, put the information into the AVS, even start some of those interventions even before the provider comes in the room. I mentioned several times the role plays, and I really do think this is helpful. I know I've gotten a lot of good feedback from our residents when we've done this, just feeling like they gain a lot of confidence, but also are able then to do these interventions a little bit quicker if they've kind of practiced it ahead of time and have some scripting for how to do it. Certainly, as I know many people on this call already know, this is a great opportunity for resident PI projects, and having resident champions who are advocating for these things really does increase awareness and leads to improvement in intervention rates. And then I think also sharing intervention data with providers and just having a lot of just people being aware of what the intervention rates are and what some of the goals are can be really helpful in increasing rates. I know we've also done some competitions within our clinic. Our residency clinic is set up in a pod system. So we have lemon, lime, and orange pods. And those pods have specific providers and clinical staff. And so we've challenged the pods to compete against each other to see which pod can have the highest rates. And there's been a lot of friendly competition around that. And then usually at the end of the competition period, we'll get baked goods or pizza or whatever for the winning pod. And we've seen a lot of great engagement with that. So a lot of strategies to just try and kind of get people on board with doing these interventions and keeping up the momentum. So I am going to stop there and open it up if there are any questions or if people have other comments or other strategies that have been helpful for them.
Rebecca?
Hi, thank you for your presentation. I wanted to ask a question. I'm not sure why I'm echoing, but I wanted to ask a question about how this works practically. So the patient fills out on paper, the provider reviews the information. Where is the information documented? Is it documented in the newborn chart? Do you try to find the mother's chart? Do you have this in any EMR at this point?
Yeah, great question. So yes, this is fully integrated into Epic, and the implicit network has like a Amy can talk more about this, but it has a Epic build for the ICC questions, and so every site has a different workflow, but generally at our site, the way it works is we actually have like a laminated form that has the questions on it. So the clinical staff is taking this laminated form into the room, giving it to the mother birthing person as they're rooming the child. The mother birthing person is filling it out. When the provider comes in, they review it and then they enter it into Epic in the child's chart. So all of this is getting documented in the child's chart in Epic. And then if there is a positive risk factor that is leading to an intervention such as like a prescription or something where the mother's chart needs to be accessed, then what we're typically doing is opening up like a telephone encounter and just writing like, this patient was seen during their child's well-child visit, positive risk factor for tobacco use, nicotine prescription written, just so there's some kind of documentation. But the full screening is all being documented in the child's chart. And I know there are different variations in how that's being done. Some sites are using like iPads so that the information is just flowing directly into the EHR. So lots of variations in how that can be incorporated.
Thank you very much, Brianna. I am going to move to the next section just in adherence with time. Please, if you have any additional questions, put them in the chat. We will have time at the end of the meeting to also have any additional questions too. So now we are going to turn it over to Mike to look at some ICC behavior change data.
All right. So you guys should be seeing my slides. Is that correct, Anna?
Correct.
Okay. Okay, so in terms of behavior change, this has always been a challenge. And actually, Brianna, I think your presentation was spot on to lead into this because I think it defines, you know, what are we classifying as risk, and then what do we, you know, term in terms of interventions, and that flows nicely into the ultimate goal is how do we define behavior change to identify outcomes, achieving outcomes as part of the ICC project. And this is actually building on information that I presented in the fall meeting in Providence. And so some of this will look familiar, but I did a number of adjustments to the methodology in terms of classifying what constitutes behavior change. And so I'll go through that. And then the other key piece that I added was looking at behavior change profiles across the implicit sites. One of the things I noticed in kind of preparing the fall data is that across our sites, we have a lot of variability just in terms of the risk profile and then also kind of the behavior change profile. And I thought that was kind of interesting. So I'll be presenting that as well. So let's jump into, so the current framework that we have in the what we call the R report. So there is a report that exists. It's created in R, which is a open source free statistical software package that we use to essentially automate the process of extracting out all of our data from the REDCap database and providing, whether it's at a site level or the network level, kind of a nice summary of everything from screening rates to intervention rates to risk rates and so on. And so this R report does have a section in it that calculates behavior change. And the current methodology that's used to determine behavior change in this report is one is calculated at the birthing person level, and it's basically saying at any of their well child visits, if they were at risk and at the next visit they were not at risk, that's considered a behavior change. So it kind of, again, looks at it at the birthing person level and says, hey, you know, if they had 6 well child visits or 7 or 2, if they were at risk at one of those visits and at the next visit they were not at risk, that's considered a behavior change. So it's kind of a crude, just a very binary kind of thing, but that's what's currently in that report. There's also a second method that's included in the report, and that's at the well child visit level. And that just simply says, you know, how many instances did we have a well child visit where a risk was identified, and at the next well child visit they were not at risk? That constitutes a behavior change at the well child visit level. So we calculate it both ways in the current R report. And that, again, just kind of setting the foundation of where we have been in the past. And this is just a graphic that shows what it looks like for depression at the birthing person level, and some of the output that's in the current R report that shows by site the risk level here on the left, and then the percent change. In other words, did that birthing person at some point in their trajectory over the 2-year time frame, were they at risk, and then they at a subsequent well child visit they were not at risk. In the fall, at the fall meeting, I spent some time kind of going over this, is just the challenges of defining behavior change. With ICC, we have a lot of variability just in terms of the spacing of well child visits. These birthing persons are not coming in at regular intervals. So we have, obviously a varied number of well child visits across the 20-month, that first 2 years of life. We have a lot of instances where ICC is not assessed at every well child visit, or parts of ICC are not done. You may have done smoking and depression, but you didn't have time to do contraception and multivitamins. So we don't have these assessments done at every well child visit. We have sites and or birthing persons entering and exiting the kind of that project time frame. And so again, it's not always consistent. We don't have a control group, and defining the cohort that we want to measure behavior change is really a challenge. And so as an example here, I have several birthing persons laid out here that I extracted out of the database just to show you what their visit trajectory looks like over a 24-month period. And so for birthing person A here, they had a visit in month 0, they had a well child visit in month 2, month 4, month 7, and month 22. And so you have this huge area here where there were no well child visits documented for this particular birthing person. Here's birthing persons B and C. They had no well child visits recorded for these first, those newborn visits. And so we kind of have this gap in the early stage of life for that child. And perhaps they were new patients to that practice, and they were picked up later in that trajectory. Here's a letter D. Here's a birthing person with 3 visits in that first, kind of 3 newborn visits, probably maybe a problem or some kind of acute need, and they were recorded as well child visits. And so, again, my point here is just saying that we have a lot of variability across that 2-year time frame, and trying to define a cohort to say, hey, are we observing behavior changes is really a challenge. So how do we go about defining that cohort? And so for this kind of new method of defining or measuring behavior change, I'm trying to define what that cohort looks like. And again, would be interested in your feedback if there are elements that you feel would be helpful to help us narrow down this definition. So essentially, I'm pulling data from our phase 3 database. It's our largest database and the most recent one. And essentially what I'm doing is I'm classifying each of the well child visits into one of these 5 categories based on the child age in months. And the criteria to be included in this behavior change assessment is they must have at least 4 of these 5 different categories represented. So you, as a birthing person, you must have been in at least, 4 of these 5 child age categories. Now, again, as a network, we could decide that we want to alter that and make it 3 of the 5, or maybe change the age categories. I'd be interested in feedback on that, but that's what I kind of set up as a mechanism to help say that, we want to measure behavior change on birthing persons across, a larger spectrum as opposed to just, the first 3 months or something. We want to kind of have that comprehensive ICC overview and be able to look at behavior change across that spectrum. Now, the one thing that I had included in the fall that I took out is I had a criteria in here that they had to have at least one well child visit in the 0 to 3 month window of the child age, and I took that out simply to accommodate instances where we have a birthing person who's new to a practice and they may have entered kind of in, maybe their first visit was at month 6 or month 4 or something like that. So I did remove that. Again, for this data, that's something new. It did add a number of additional birthing persons to the data set. And so this is a summary of what this cohort looks like. The raw data export that I pulled from REDCap included 27,000 birthing persons, or dyads. I often use dyad to represent the birthing person / child grouping. And that also included over 100,000 well child visits. But once I applied this criteria, it was essentially the cohort was reduced to 5,207 birthing persons with about 42,000, a little over 42,000 well child visits. And I included just kind of a histogram here, just showing the age of the child at the well child visit for this cohort. And you can see how, and then the dashed lines just show you the dividing time frames that correspond over to the various the 5 age groups that are specified. And you can clearly see that the number of well child visits in these latter child age categories really start to get small. So the demographics of this cohort, I'll just quickly go through and just show you what this what this cohort looks like. So this is the breakdown by site, and so you can see some of the sites have obviously very large numbers or contributing large numbers to this cohort of 5,207 birthing persons, and some sites are very small. Oops, jumped too fast there. Okay, and then just in terms of the year of birth, ranging from 2018 to very early in 2023 that are included in this data set. If we look at just some demographics of the birthing person, so education level. So again, just trying to paint a picture of this particular cohort. If we look at insurance, no surprise there, very heavily medical assistance, so we're 50% medical assistance for this cohort. If we look at it by the breakdown of race and ethnicity, so these are the raw race and ethnicity categories that we collect as part of the implicit ICC project. And so again, the way this is displayed here you can have a birthing person in more than one category. So they could be white and Hispanic, they could be white, Black, and Hispanic. And so again, just the percentages will not add up to 100 because we do have birthing persons that are clumped in multiple categories. And then for the fall meeting, I had also parsed it out. We were looking at a lot of equity kind of comparative information. And so I had also created a BIPOC group. And now this is not, you can't be in more than one category here, but the definition is at the bottom of the slide. But in terms of that percentage, so about 36.5% fall into that BIPOC category, but we also have a high percentage, about 35% missing or unknown in our demographics. So in looking at the well child visits for this particular cohort of 5,207 birthing persons, representing about 42,700 well child visits. So if I break that down by the 5 child age categories, and this is the percent of whether ICC was completed or not completed, or a partial completion, or a mom not present. This is what that breakdown looks like. And so you can definitely see when we get out here to the latter child age categories that all ICC group here gets a lot smaller. So we definitely, at the earlier child age ranges, we definitely are doing more comprehensive ICC, and we get to the end. And it's also interesting too that we have other folks bringing in the child as opposed to the birthing person. So you can definitely see that red category increasing across time as well. And if you want to look at it just simply by frequency, just in terms of a count, again, emphasizing the fact that the latter, as we get into the latter time frame of the ICC 2-year window, we see fewer and fewer well child visits from these birthing persons. In terms of this cohort of 5,207 birthing persons, this is just a histogram showing you the distribution of the total number of well child visits that they had. So the average was about 8.2. And if I look at the entirety of the phase 3 database of folks, including this cohort, as well as folks that would not be included in this cohort, our average runs around 4. So obviously this cohort, by putting those restrictions on, we're essentially doubling the number of well child visits that we've seen for this, for these folks. So again, it's just some interesting discussion in terms of how we want to define a cohort in terms of specifying behavior change. The average number of screens by the 4 risk areas. So this is just simply saying is that about 5.7 well child visits smoking is screened. About 5.5 visits depression is screened for this cohort. Contraception is the lowest, and multivitamin is about the same as the depression. So we on average tend to screen smoking more often than any of the other risk areas, and contraception is actually the lowest. And just in looking at across all of the screens themselves for this cohort, essentially what I'm showing here is for our birthing persons, at least one positive smoking screen. 19.4% of birthing persons had at least one positive, and then about 78.5% had no positive smoking screens. And we did have 2.1%, even though we had at least 4 well child visits for these birthing persons in the cohort, we had 2.1% of them that never had a smoking screen completed. And similarly for depression, we had 21.2% had at least one positive screen for depression. And, again, probably more concerning, 3.4% had never had a screen for depression, is in this cohort. So Contraception. So we had about 55% had at least one positive risk for contraception. And again, about 3.6% never had a screen for contraception. And for the multivitamin, this is the one where we tend to see the highest risk rates. So about 75% had at least one positive screen for a risk in multivitamin, and 2.3% never had a multivitamin screen. So behavior change. In the fall, I had defined a kind of a new framework for defining or calculating behavior change. And it was something that I had encountered a while back in some work I was doing with some GIS related items. And it's a kind of a space-time summary of identifying emerging hotspots. And essentially, how can you measure something over time and detect patterns, and which is essentially what we're doing here across that 2-year time frame of well child visits. And so I ended up modifying the kind of the framework that they are using for some GIS related analyses. And I came up with this schema here. They created 5 categories. And so we, kind of on each end of the spectrum, we have either the always non-risk. So these would be individuals who never screen positive for a smoking risk, as an example, or never screen positive for a depression risk. And then on the other end of the spectrum, we have the folks that are always at risk. So for all the well child visits that we have for them, they screen positive for a smoking risk, or they screen positive for a depression risk. And then in the middle, we have an intensifying, what I called an intensifying non-risk. In other words, they're trending towards where we want them to be. They're trending towards not having a positive risk. And then we also have a group down here that they're actually trending in the wrong direction. They're actually intensifying that risk. In other words, they're trending towards more and more well child visits where they're screening positive for a risk. And then we had a category in the middle called this oscillating group, where we really couldn't discern any type of trend. And then I had specified the definitions here. So the intensifying non-risk group, I essentially took all the well child visits that each birthing person had, and I split it in half. So if they had 8 visits, 4 and 4, and essentially if the second half was had a greater non-risk rate than the first half, they then fell into this intensifying non-risk group. And similarly, the intensifying risk group, I just split it in half, and if the risk rate in the second half was greater than the first half, then they were classified as intensifying risk. And the oscillating group was just simply, if I split them in half and they kind of had equal rates in the first and second half, that essentially classified them as, we really couldn't discern any type of trend. In thinking about it and just kind of looking at some of the data in terms of what that method represented, I actually ended up coming up with a modification. I kind of jokingly calling it the phase 2 of the behavior change. And I think, in my opinion, I think it actually does a better job of really trying to tease out, is there a kind of a trend towards increased risk or decreased risk? And essentially, this schema here has 6 levels, and the always non-risk and the always risk groups never change. I mean, those are the same as before. So these again are people that are birthing persons that either always at risk at every well child visit, or they're never at risk for all of their well child visits. And essentially, what I did is I took that oscillating group and I split it into 2. And so the definitions have changed. And so what I did is, for the intensifying non-risk group, I essentially create a regression for each mom or birthing person. And I take that regression and I'm looking for, if I take all of their well child visits and string them out in time order, is there a linear trend in that particular birthing person, either positive or negative? The positive would be the intensifying non-risk, and the negative would be the intensifying risk. So I'm basically using a statistical technique to try to identify some, some trend in, across their respective well child visits. And if there's no statistical trend and they have, risk, non-risk well child visits, then they fall into this oscillating, one of the two oscillating groups. And essentially, if there's not a significant trend, and less than 50% of their well child visits they're at risk, they're considered oscillating non-risk. And if more than 50% or more are at risk, then they fall into this oscillating risk group. So I think, for me, I think one of the advantages here is it really leverages all of the well child visits as opposed to just kind of splitting them in half. And I think it kind of just uses a little bit more systematic mechanism to say, yes, there's a trend here, or no, there is not a trend. And in the slides, I just included a couple examples. Again, I just extracted out some sample birthing persons just to kind of show you what this looks like. And I know this is very colorful and very busy, but so this P1 here, this is what I presented in the fall in that original scheme that I created. And then this is the P2 column here. This is what they were classified as with this new scheme. And just so you can interpret this a little bit, I pulled out just sample birthing persons that had at exactly 8 well child visits, just the average, just to kind of show what it would look like in a consistent way. So this would be well child visit 1, well child visit 2, well child visit 3. So each column is the sequential number of the well child visits. And each row is a unique, each row here is a unique birthing person. So this first birthing person, they were at risk in for smoking. This happened to be smoking. They were at risk for smoking in visit 1, visit 2, and then the rest of their well child visits, they were not at risk. So they didn't screen positive for smoking in any of the subsequent well child visits. And so in both of the schemas here, they were classified as intensifying non-risk. So again, you can kind of see how you would go through and be able to see what are the potential scenarios. Some examples of scenarios of well child visits and the risk screens that could appear. The one that made me a little bit uncomfortable is if you look at the birthing person number 12, so they were screened positive for smoking at all of their well child visits except the very last one. And in the old scheme, this was considered intensifying. Actually, that's incorrect. That should have probably be. Oh no, that is correct. Sorry, they were classified as intensifying non-risk because if I split their well child visits in half, they had a smaller proportion of risk in the second half. They were also classified as intensifying non-risk in the new scheme because if you graph this as a linear, and in terms of a linear trend statistically, that does fall out as being a significant trend downward. And I was a little uncomfortable with that. I noticed that in the new scheme, if you had any instance where all of the visits except one at the very end were at risk or not at risk, and then that one at the end was the opposite, they fell out as being a significant trend. So I was actually playing around with some other ways to potentially handle that particular scenario. And again, just as a graphical representation of that, I like data charts and graphs, so I have to include a lot of that stuff because it's just fun to look at this in a number of different ways. But over here on the right, I added, in addition to the table, I just showed you visually what that trend line looks like for each one of these sample birthing persons. And so you can see in, as an example, if I look at birthing person 5, 6, and 9, all of those are classified as in that oscillating category. Because that slope isn't great enough to become statistically significant. But these others, you can definitely see that the slope is much greater, and that's essentially what's happening to create that intensifying risk or intensifying non-risk categories. So what does it look like when we apply this new kind of phase 2? So just as an example, here's the contraception. This top graph here is from what I presented in the fall, that schema that I presented in the fall. So this is what it looks like in this current cohort, and here's what it looks like using the new cohort. So one of the things you'll notice is these categories don't change. They're the same between the two schemas. But what you do see is when you look at the internal and essentially the oscillating and the intensifying categories, that's essentially what is changing the distribution between the two when you apply this new classification method. So if we look at the phase 2 or this new classification method, so this is what it looks like for smoking. So essentially we had a little over 80% of our birthing persons that were always screening negative for smoking risk. And we had 6.4% that for all of their well child visits were always screening positive for that risk. And then you can see that 2.3% were kind of in this intensifying non-risk. In other words, that linear trend was towards not screening positive for smoking. And then we had 4.6% that were the slope was upward, and that they were essentially increasing the number of well child visits where they were screening positive for smoking. And if I flip to depression, again, the same interpretation here. 78.1% of our birthing persons never screened positive for depression. And then of those that screened positive at some point, here's the breakdown in terms of taking all of those well child visits and breaking them down into what categories they fall under in terms of behavior change across the spectrum of all of their well child visits. Contraception, we have a lot more risk in screening positive for risk in contraception, so that dark green bar gets a lot smaller. And again, you can see the distribution across all of the categories. And finally, multivitamin. Again, as I said before, multivitamin is the one area where we have the highest rates of risk, screening positive for risk. So one of the things I presented in the fall as well was just some associations with behavior change and the birthing person demographics, just to see what are factors associated with this schema. So again, this is using the new schema with the 6 categories. And so for smoking, the p-values or I should say the odds ratios that are in green, those are statistically significant. The blue ones are not. And essentially what you're looking at here is, so let me take an example. If I come down here to the insurance section, I set up private insurance as the referent group. And essentially what this is showing is that the medical assistance, the birthing persons that are identified as being on medical assistance have a 2.8 times higher odds of essentially moving down towards higher numbers on this particular, on the scale, the behavior change scale. So they are more likely to be in those upper categories in terms of the behavior change schema, the birthing persons in that particular category. And then similarly for, if you look at education, the greater than a high school education, the referent group here is less than a high school education. So compared with those with less than a high school education, those with greater than a high school education actually have a decreased odds of being in those high. So they're essentially, what that's essentially saying is they're more likely to be in those lower rungs or lower categories in terms of risk. And similarly, if we look at the race and ethnicity categories, I just for simplicity, I use that BIPOC classification. And our BIPOC population here is actually has a lower, they're actually classified in those lower categories relative to the referent group here, which actually is the non-BIPOC group. And if we look at the same, if we look at the same for depression, again, we see that the BIPOC group is significant when compared with the referent group, the non-BIPOC group. Again, that suggests with the odds ratio less than 1, that suggests that they're more likely to be in lower categories. And similarly, our medical assistance group out here, again, has an increased odds. So they're going to be in the higher, they're going to actually be at the other end of the spectrum. So they're going to be more likely to be up in the higher purple range of our behavior change scale. Contraception, very, very similar output, but again, the less than a high school education or less likely, they're more likely to be in the behavior change toward the lower end. And similarly, this is interesting, the birthing person age. Essentially, older birthing persons are going to essentially, again, more likely to be in that lower rung. And then in this particular instance, our BIPOC population is actually more likely to be in the higher behavior change categories versus the non-BIPOC population. And then finally, multivitamin. Again, similar, you see an impact of insurance. So our medical assistants birthing persons are going to be more likely to be in this upper range. Same with our BIPOC population. They are more likely to be in that upper range. Older birthing persons are less likely to be in that upper range. They're more likely to be in the lower range, and so on. But again, you get the idea of how you can use this to sort out some of these demographics and figure out which ones are associated with where birthing persons fall in that schema. And then finally, the other thing that I wanted to do is just share what this looks like by site. The one thing I will say with the sites, I did restrict them to, so any site that had less than 30 birthing persons included, they were excluded from this summary just because the N gets really small. There were a couple sites that just didn't have enough in the cohort here. So if you don't, excuse me, if you don't see your site here, that's why. So for smoking, this is what the breakdown in percent looks like across all of these 6 risk change categories, and I ordered them based upon the always non-risk group. So you can see at the very top here, McKeesport. They actually, and if you think about it, any of the non-dark green, that's essentially your birthing persons that have at least one risk identified for smoking. across all of their well child visits. So McKeesport has the highest risk rate overall. And again, I think one of the things that was astonishing to me was just how much variability there is from McKeesport all the way down to Tower Health, just in terms of the overall birthing person. Did they ever screen positive? That's essentially what it's telling you. Did they ever screen positive for smoking? So we have a great level of kind of diversity across our sites in terms of some of these risk areas, which I think is really interesting. And so again, you can see what that distribution looks like in terms of these behavior change categories. And then just again, another way of looking at it, I excluded the always non-risk group. So that dark green group, I took them out. So this is essentially looking at all of the birthing persons that screen positive at some point during their well child visits, and kind of looking at it that way. And so, so again, you can interpret the percentages here. So it looks like about, if I extrapolate a line, that's not a straight line, but it's close enough. So about 45, 46, 47% of the McKeesport population screens positive at some point during that well child visit trajectory. So I think that's really interesting compared with, like, for example, Tower Health, about 5%. So we again just have a huge amount of variability across our sites in terms of what types of risks that you're seeing in the clinics on a regular basis. And so again, very interesting. And again, of those that were at risk at some point, here's the breakdown of how many birthing persons are in that oscillating category, how many of them are in the intensifying risk or intensifying non-risk groups. They're heading the right direction or the wrong direction, kind of thing. And then one additional way of breaking it down, I just included the intensifying non-risk and the intensifying risk group. So again, these are the folks that statistically have some sort of linear trend towards either, across their well child visits. They have this linear trend that says, I'm screening positive less often, or I'm screening positive more often as the well child visits accrue. And so I have them ordered by the kind of the intensifying non-risk group. So I ordered them based on that green, because that's the direction we want them to head. And so, for example, UPMC Altoona had the highest rate, kind of along with Shadyside there, had the highest rates of, birthing persons kind of with that linear trend heading in the right direction in terms of decreasing amounts of risk across the well child visits. And then you can contrast that with the kind of the purple side. But they also, Altoona as an example, also had a huge, a large percentage heading in the wrong direction, so to speak, where they have a linear trend of, birthing persons increasing their smoking as the well child visits accrue. So if we look at it the same for depression, so again, for depression, again, it's just striking in terms of where are we seeing, very high rates of risk compared, across some of the sites. Some of the sites have very low risk. So this is, again, the entire schema. And if I get down into just the ones, so these, again, these are the birthing persons that would have screened positive at least once during all of their well child visits. So I'm excluding that always non-risk group. So we have Williamsport, over 50% of their birthing persons screened positive at some point during that trajectory, and that's significant. And then again, you can see as you go down across the other sites, some of them very, very low rates of depression in screening positive for depression in some of these other sites. And then similarly, again, kind of looking at it, this diagram, just showing you the birthing persons heading in the positive direction, birthing persons heading in the negative direction. Again, just seeing that variability across sites of, there certainly are some sites that have a number of birthing persons heading in the right direction in terms of screening positive less often. Contraception, again, this is one where we see a lot higher risk rates across all of the sites. But again, there's still a lot of variability here. And if we jump to the rates by site for at least some risk, I mean, you have New Hanover with 80% of their birthing persons screen positive for a contraception risk at some point. And again, compared with some of the others where it's less than 40%. So again, significant variability across all of our sites. And again, looking at the contraception, this one was interesting to me because we're seeing much higher rates in the green here of being able to, towards the latter phase of the well-child visits, be able to influence some sort of positive trajectory and behavior change. So this was the one risk area that I would look at and say, hey, it does seem like, you know, for contraception, we're able to influence and be able to, you know, create that positive linear trend of decreasing risk in a much higher percentage of our birthing persons. And then finally, for multivitamin, our highest risk rate area. And so again, you know, like University of Mississippi, you know, about 90% of their birthing persons are at risk at some point. Maybe not as much variation here as some of the others, because this is just generally tends to be a very high risk. People are screening positive a lot for this, but still some variability, perhaps not as much as some of the others. And then finally, the last image there, just showing that positive trajectory, the negative trajectory, much heavier emphasis on the negative trajectory here. It seems like we have a lot of birthing persons that may have been on multivitamins early in their well-child visit trajectory, but then, you know, screen positive for risk, you know, later on. Just some quick conclusions. Again, the challenge here is really how do we define behavior change? How do we define a cohort? You know, certainly a cohort that we want to measure behavior change on at the birthing person level. We definitely need some inclusion exclusion criteria to do that. And saying that we probably want some minimum number of well-child visits across various you know, time frames based on child age. One of the things I've noticed generally is risk rates differ. So from the cohort here, where we had an average number of well-child visits of 8 compared to the general REDCap database, where it's only about 4, our risk rates seem to be higher. And I think some of that is we're seeing these birthing persons for more visits over a longer period of time. And, you know, does that increase the likelihood that somebody's going to screen positive at some point, or are these higher risk birthing persons to begin with? So I think it's just some interesting questions there, you know, and can be influenced of how we define that cohort. I do like the phase 2 approach better that I just presented. I think it better handles that oscillating group and separates them out in terms of, you know, these are clearly individuals that are kind of bouncing back and forth between risk, non-risk, versus somebody that actually has a trend. So I think this approach is a little bit better, at least in my opinion. And, you know, one of the questions I had too is, you know, is this something I should add to our overall report, that we can report on this, you know, on a regular basis? You know, again, just some, you know, input from the group here, as well as the data committee, would be helpful in terms of what to do with this, you know, in terms of the next step. So I'm going to stop sharing at that point. Anna, I'll turn it back over to you. Questions or whatever's next on the agenda.
Thank you very much, Mike. I know we are getting ready for a break and we're a couple minutes over. That being said, we still will take our full 30-minute break. Some of our later sessions are going to be a little bit shorter than scheduled. So while this is fresh in everyone's minds, I do want to give the opportunity for some questions while we have Mike here. So it looks like Amy, you have your hand raised. I'll let you go first.
Mike, can we define the cohorts well enough to look at it at an intervention level to create SMART goals to say, like, all right, are trending positive versus trending negative? We want to flip those, invert those numbers over the next 6 months, or is it easy enough to define the cohorts for that?
When you say define the cohorts, are you talking about saying, hey, here's a group of birthing persons that are in cycle right now that we're actually still seeing, as opposed to they've completed the entirety of the 2-year time frame?
Right. But we say, all right, all of these patients had a visit prior to us doing an intervention, and then we do something, a training or something to try to improve our contraception rates or multivitamin rates. And then can we look at it afterwards? Is it easy enough to define?
That's a good, yeah, that's a great question. I mean, I think the way I've defined a cohort in the fact that they had to have had a well child visit within 4 of those child age categories. My fear is you're going to be capturing people right at the end of, most likely, they're going to be close to the end of that 2-year well child visit time frame. I'd almost think we'd have to define that cohort a little differently and say, hey,
yeah.
here's a cohort that we know is at risk at least once during the first 3 months or the first 6 months, and then track them for the next 18 or something and say, hey, we hope to have a negative slope on these folks by the time they get to month 24. Does that make sense?
Yeah.
But I think we could do that. We would have to just play it, maybe the data committee or somebody, we'll have to have a subgroup or something work on that and try to figure out what that looks like.
And it's a fascinating way to look at the data. And you're right, I think it works better than our previous change between 2 visits. Thank you.
Rebecca?
I think you answered my question. Thank you.
Laura?
So is there a way to pull the data for payer mix? So, if there's a significant increased risk for patients who are on Medicaid, and say, for example, then Altoona has a lot more people at risk for smoking, is there a correlation? Does that mean, does Altoona have more Medicaid patients compared to like some of the other sites?
Yeah, great question. I mean, really what you're asking there is is there an interaction effect with the payer mix and the site? Or some of the other demographics, there could be interactions there too. Some sites might have a very high numbers of birthing persons with less than a high school education, which we saw was a risk factor. They may have younger moms, which may be a risk factor. They may have, a higher proportion of BIPOC or non-BIPOC, So any of those factors, yes, we could easily model that or tease that out and say, what is the effect of that within particular sites or that interaction effect? So yes, that certainly could be done.
Thanks.
Do we have any other questions? All right. Oh.
Mike, I caught it before you explained it, but for years we were looking at the box plot of how many visits we had data per kids in a cohort or whatever based on their birth year. And I know that it's 4.5 or something like that, but there is obviously a range in that box plot, and you've pulled out a cohort. Which is different than sort of the way we've been looking at that. Is 8 the right number? Or did we play around with you know, like, I think the question for me is, we're at a spot where we really want to identify and limit down to, you know, for people who are exposed to this model. And we know we work in places with a 50% Medicaid population, you know, where people are coming in, leaving out, missing visits, things like that. And so we've defined that based on, you know, prior work in the network, that people come and go, and, you know, not everybody has 10 well child visits where ICC is done in the first 24 months. But by saying, let's look at a, you know, fidelity to the model, which is a conversation that we've had about, you know, sort of from a science perspective, we really test the model. This seems to, you know, test it a lot better, when you can really say, you know, eight visits where this was done, or 8 chances, you know, does this model work, or what can we say about it? But is it 6 visits, 8 visits, 10 visits? You know, did you play around with that, or are we, you know?
I didn't, and and I like your fidelity to the model phrasing there of what we're trying to do. And we could certainly, you know, kind of do a sensitivity analysis to figure out what does it look like when we try this, and how does it compare. And my definition of the cohort was just simply based upon they had to have had well child visits in 4 of those 5 child age categories, and just naturally then parsed out to, gee, the average was 8, with a minimum of 4. So, but we could loosen that up a little bit and say, hey, maybe 3. We'll say that they had to have, because of our population, maybe we'll relax that and say they had to have had visits in 3 of those categories, and maybe that takes us down to 6, average of 6 well child visits, and see what that provides. But yeah, the question is, where is that threshold of fidelity to the model crossed, of we feel comfortable with it, or no, we don't feel comfortable because we have all of these in and out flow in our practices, and the, you know, medical assistance, you know, phenomena, et cetera. So
Yeah, and I want to correct myself, because you showed us the sort of the sample of 12 different visits that all had 8 visits, each. But I actually thank you for correcting. It isn't that they all had 8 visits. It's just that was the average, in this cohort, which got you. Okay. Well, thanks for clarifying that. I don't know the answer, but I think that the sheer fact that if you looked at this population of people, which is fairly representative of, you know, birth parents over the first 2 years, you know, 40,000 visits, 5,000 parents, all these different locations and practices, to say that at any single point in there that, you know, 50 or 80 or 90% of people have a risk factor at least once, you know, that we're able to capture in a very reliable way, I think is, you know, probably not super surprising, but certainly new information, right? How else are you going to answer that question, whether or not, you know, what proportion of people are not taking multivitamins in the time they're supposed to be taking multivitamins, or so on and so forth. So just very impressive. Thank you.
Yep.
Any other questions? All right. I know the data portion can be a lot, and it can take time to kind of sift through everything. So we will also be sharing the slides that Mike put together, and if you're interested in kind of discussing this further, we can definitely set up some meetings. And like Mike said, he'll be here after lunch. So if there's further questions, feel free to put them in the chat. So we will be having a break now. Originally, we were to be back at 12:10. We will now be back at 12:25. So please enjoy your break, and we will see you all back here at 12:25 when we'll dive into 4th trimester.